After completing the bony portion, we begin the second part of the mandible. Several ligaments manage the temporomandibular forces and send multiple proprioceptive afferents. The proprioception of the joint is provided by various components, such as the capsule, masticatory muscles, skin receptors, and receptors within the periodontal ligaments. The tension perceived by the articular ligaments plays an important role in the function of TMJ. The temporomandibular joint is a diarthrosis. It has classically been referred to as being a condylar and functionally as a double condylar joint that consists of two articular surfaces, an intra-articular disc, a capsule, and ligaments. Let's begin from the ligaments. Sphenomandibular ligament originates from the sphenoid spine in the greater wings of the sphenoid and descends onto the medial surface of the mandibular ramus, attaching to the lingula. The mylohyoid nerve, which arises from the inferior alveolar nerve just before it, enters the mandibular foramen. The mylohyoid nerve does not enter the hole, but perforates the sphenomandibular ligament and runs antero-inferiorly in the mylohyoid groove of the mandible with accompanying vessels. The sphenomandibular ligament also has contacts with the pterygomandibular fascia, the lateral pterygoid muscle, the internal maxillary artery, whose major branch, the middle meningeal artery, ascends to reach the foramen spinosum and entering the middle cranial fossa where it runs, as we saw in the video on the temporal bone, into the sulcus in the squamous part of the temporal, and with the auriculotemporal nerve and the inferior alveolar nerve, both branches of the mandibular nerve. Its main task is to protect the TMJ from an excessive translation of the condyle after 10 degrees of opening of the mouth. When we studied the temporal bone, we saw the muscular and ligamentous insertions to the styloid process. In particular, two ligaments originate from these structures. The stylohyoid ligament, which inserts into the lesser horn of the hyoid bone and provides part of the origin of the middle constrictor muscle of the pharynx and the styloglossus muscle, and the stylomandibular ligament, which arises from the stylohyoid process of the temporal bone to the mandibular angle. It is considered a thickening of the deep cervical fascia and serves to limit excessive protrusion of the mandible. When we studied the occipital bone, we referred to the pharyngobasilar fascia that is a part of the middle layer of deep cervical fascia that surrounds the pharynx, along with the buccopharyngeal fascia. The pterygomandibular ligament, or raphe, is a thickening of the buccopharyngeal fascia. It arises from the apex of the hamulus of the internal pterygoid plate up to the posterior area of the retromolar trigone of the mandibular bone. Some muscles are in contact with this ligament. Anteriorly the buccinator muscle and posteriorly the pharyngeal constrictor muscle, muscles that we will study when we talk about swallowing. The direct connection of the middle ear with the temporomandibular joint is through Pinto's malleolar disc ligament, or discomalleolar ligament, which arises from the malleus, one of the middle ear ossicles, and runs to the medial retrodiscal tissue of the TMJ. It extends from the postero-internal portion of the disc of the temporomandibular joint, penetrates the petrotympanic fissure, and reaches the middle ear malleus. It thus possesses two parts. The first involves the middle ear and involves the malleus. The second involves the extratympanic area, that is, the portion of the TMJ joint capsule in contact with the retrodiscal tissues. From this view, we can see another important ligament, the temporomandibular ligament or lateral ligament, which consists of two fascicles. The outer oblique layer, fan-shaped, inserts on the articular tubercle and neck of the condyle externally. Its fibers are directed downward and backward, and the inner layer with fibers with a horizontal course that extend from the tubercle to the lateral pole of the condyle and the posterior portion of the disc. The articular disc is made of fibrous connective tissue, which is not supplied by any nerve or blood vessel. The posterior attachment, retrodiscal tissue, is highly vascularized and innervated, and is bordered by retrodiscal lamina, superiorly and inferiorly. The articular disc is attached superiorly and inferiorly to the capsular ligament, which covers the entire TMJ. Anteriorly, the disc is attached to the superior lateral pterygoid muscle fibers. Anteriorly, the superior and inferior aspects of the disc are also attached to the capsular ligament, which surrounds most of the joint. The superior and inferior attachments are to the anterior margins of the articular surface of the temporal bone and condyle, respectively. From this image, we can see the capsular ligaments, which covers the entire TMJ, and the collateral or discal ligament that connects the articular disc medially and laterally to the condyle. The medial discal ligament attaches the medial edge of the disc to the medial poles of the condyle. The lateral discal ligament attaches the lateral edge of the disc to the lateral poles of the condyle. TMJ is related to different muscles that have the function to move and protect the joint itself. On the outer face of the mandible, we find the insertion of the temporalis muscle on the coronoid process of the mandible. The buccinator, its superior part, arises from the outer surface of the alveolar process of the maxilla. The inferior part arises from the alveolar part of the mandible. The posterior part originates from the anterior margin of the pterygomandibular raphe, a fibrous band that extends from the pterygoid hamulus to maxillary tuberosity. Some of the back fibers of posterior origin attach to the retromolar triangle. The platysma. It originates in the upper thoracic and shoulder regions from a fascia that covers the pectoralis major and deltoid muscles. Its thin muscle fibers cross over the clavicle and proceed obliquely superiorly, laterally, and medially over the neck and attach just behind the symphysis menti. The fibers travel superomedially over the anterolateral aspect of the neck to insert on the mandible, the skin, and subcutaneous tissue of the lower face. The masseter muscle originates from a thick aponeurosis on the temporal process of the zygomatic bone in the anterior 2/3 of the inferior border of the zygomatic arch. The fibers of the superficial portion pass over the deep portion and insert onto the angle of the mandible and the inferior portion of the lateral surface of the mandibular ramus. The deep portion of the masseter muscle originates from the entire surface of the zygomatic arch. On the inner surface we can see the muscular insertion of the buccinator, temporalis, internal pterygoid and superior pharyngeal constrictor, and ligamentous insertion of the pterygomandibular raphe, the stylomandibular ligament, and internal fibers of the lateral or temporomandibular ligament. Staying still in the internal portion, we can see again the geniohyod muscle that originates from the inferior mental spine, located on the posterior surface of the mandible near the lower part of the mandibular symphysis. From there, the muscle fibers radiate postero-inferiorly, close to the central line, and insert to the superior border of the body of the hyoid bone, the genioglossus, an extrinsic muscle of the tongue. It is a large, thick muscle which contributes significantly to the shape of the tongue. It arises from the mandibular symphysis and inserts onto the body of the hyoid bone and the entire length of the tongue. The anterior belly of the digastric muscle that originates from the digastric fossa of lower border of mandible, close to the midline near the mandibular symphysis. This portion of the muscle extends postero-inferiorly from the mandible, joining with the intermediate tendon that connects it to the posterior belly. The mylohyoid muscle originates from the mylohyoid line and continues along the inner mandibular rim and inserts on the body of the hyoid bone. The mylohyoid muscles on each side of the inner surface of the mandible meet medially at a median tendon called the mylohyoid raphe. From these images, we also recognize the styloglossus and stylohyoid muscles that originate from the styloid process of the temporal bone and the hyoglossus that is an extrinsic muscle of the tongue, located in the floor of the oral cavity, lateral to the geniohyod muscle. As we saw during the lecture on the sphenoid, the medial pterygoid muscle consists of two heads, superficial and deep, that are separated by the inferior head of lateral pterygoid muscle at their origin. The deep part arises from the medial surface of the lateral pterygoid plate of sphenoid bone and from the pyramidal process of the palatine bone. The smaller superficial part arises from the maxillary tuberosity and the pyramidal process of palatine bone. As these two sets of fibers descend posterolaterally, they insert to the triangular impression found on the medial surface of the ramus and angle of mandible. The fibers attach via a strong tendinous lamina that extends from the mandibular foramen superiorly to the mylohyoid groove antero-inferiorly. The lateral pterygoid muscle has an upper head and a lower head. The upper head originates on the infratemporal surface and infratemporal crest of the greater wing of the sphenoid bone. It inserts onto the articular disc and fibrous capsule of the temporomandibular joint. The lower head originates on the lateral surface of the lateral pterygoid plate. It inserts onto the pterygoid fovea at the neck of the condylar process of the mandible. It lies superior to the medial pterygoid muscle. As we have already seen when talking about the temporal bone, the temporalis muscle is a broad muscle that occupies most of the temporal fossa. Its origin point spans the entire surface of the fossa below the temporal line. Additionally, some fibers originate from the temporal fascia as well. The temporalis muscle is divided into the anterior, intermediate, and posterior parts. These fibers converge onto a narrow tendon that runs medial to the zygomatic arch. The tendon inserts onto the apex and medial surface of the coronoid process of mandible. For today, we have concluded. In the next video, we will conclude the mandible, talking about the mechanical interaction between the mandible and its muscles and ligaments.